All right, good afternoon, everyone. We'd like to go ahead and call the Health and Hospital Committee meeting to order this time. I am Supervisor Otto Lee, current chair of this meeting, with Vice Chair Supervisor Margaret Abikoga, with both supervisors present. We have a quorum. And then second item is public comments, which is for an item that's reserved for members of the public to address on this committee on any items not on this agenda. And any public who wishes to address the committee not on the agenda should speak at this time. And hi,
Hello.
how many public would like to speak at this point? Any
I don't
cards?
have anyone in chambers. I do have one member online that would like to speak.
One online speak?
Yes.
Okay, I think one online, we believe, is 3 minutes.
3 minutes. Our speaker is Parent. You'll have 3 minutes to speak. The timer will start when you begin speaking.
Thank you.
Yes, hello, good afternoon to you all. I've addressed you guys several times about my kids who are being sexually molested, and I can't get a screening for them. If I could tell you what it is, my son, he reported that my ex was letting a man rape him beginning at the age of 13. There was unnecessary bathing with the children. There was sexual contact between two of the children, and then there was extreme changes in the children's personality. You would think that all of these things combined would scream, hey, let's do a screening just to see what's going on. Let's do a screening. Let's talk to the kids. If they need protection, we'll protect them. But apparently there's a conflict of interest in this matter with the county, and a retired judge and my former attorney, Valerie Houghton. They want the sexual abuse to continue. And they're trying to stop me from trying to protect my kids. I mean, I've been physically assaulted on numerous occasions and threatened. And another component to this is that Ms. Houghton is also threatening to harm my kids. And I addressed this at the Public Justice and Safety Committee. She's sending me all sorts of advertisements, children's hospitals and children dying and all this stuff. And her modus operandi is violence. So, I mean, it's safe to assume that she's probably threatening my kids. Don't tell anybody. Don't tell anybody that you're being molested or raped or that it happened to you, or I'll harm you too. And so, I mean, how are my kids going to come forward? You want them to do it, right? You won't let me report it to you guys or to the child abuse prevention hotline. You won't let me do it to you. So what are my kids are supposed to do? I mean, she's probably threatening them. I don't know. I've not seen them in 11 years, except for my son, who told me about the rape. I saw him 60 years ago. Please, is there somebody here? I know that some of you guys are mandated reporters. You guys have been hearing me say this, and I think you guys could be in violation of something if you guys are not helping me or even reporting it to CPS. Please help me. Supervisor Lee, President Lee, he has all my contact information if you need it. Please, just a screening. That's all I'm asking for. Please help me. Thank you for your time.
Our next speaker is Jason Majors. You'll have 3 minutes. Please go ahead.
Yes, I'm Jason Majors, MFT2 with PERT. Wanted to speak on behavioral health's proposed transition plan update. Behavioral health cannot speak to whether 911 is actually diverting calls to 988 or how effectively that protocol is being implemented by not only county communications, but other law enforcement agency dispatch centers. The truth is, PERT is repeatedly seeing 988 calls redirected to 911 and then ultimately to PERT because other services within the 988 continuum won't respond, can't respond, or aren't available to respond. In just the past few months, we've documented multiple cases, loved ones calling 988 and being told to dial 911, high-risk individuals shuffled between MCRT, trust in law enforcement before PERT finally steps in, and facilities repeatedly defaulting to 911 when MCRT is procedurally prohibited from entering. In each of these scenarios, PERT wasn't a backup, it was the only viable option. There is no functional field-ready replacement for PERT, and ending the program endangers lives and puts law enforcement in an impossible position. We urge the county to continue funding this essential proven program. Thank you.
Our final speaker is Carrie Wood. Please go ahead. Carrie, you'll have to click something to accept the unmute. Your microphone is able to be unmuted. There you go.
My apologies. Good afternoon. My name is Carrie Wood, and I am the PERT clinician for the City of Santa Clara. I'm here to urge the committee to reconsider sunsetting the PERT program and transitioning its functions to the 911 to 988 backup line. The backup line will leave gaps where individuals are either left unserved or where the responsibility will fall back to law enforcement to navigate. We have documented cases between 3 agencies that PERT currently covers where 911 has either tried to transition to 988 to no avail, or where individuals who have called 988 were diverted to 911 for one reason or another. This data is only from our 3 agencies and not taking into consideration the other law enforcement agencies within the county filling an unknown number of gaps for similar reasons. This transition plan also appears to lack consideration for protocol that is utilized throughout multiple agencies that are not county behavioral health as to the way mental health crises are handled. There are multiple reasons why the PERT program is nowhere close to being able to merge with MCRT, and I urge you to continue funding this essential program. And if law enforcement agencies express the desire and the ability to fund their own clinician throughout the county, that this is considered as well. Thank you.
And that concludes public comment.
Thank you very much. So moving to item number 3, which is the approval of the consent calendar and changes to committee agenda. First, Supervisor Abikogi, you have any changes to the agenda?
No, I don't.
Well,
Happy to move the consent calendar.
I will go ahead and second that. Do you have any speaker regarding consent calendar?
I have no request to speak on item 3.
Okay, thank you so much. So let's close that and let's go take a vote.
Vice Chairperson Abekoga.
Aye.
Chairperson Lee.
Aye as well. Thank you.
Thank you.
Thank you.
Item number 4 is the recommendations relating to medical staff and allied health professionals. And here to present the item is Dr. Patricia Salmon.
Good afternoon.
Good afternoon.
This is Patricia Salmon. I'm the Enterprise President of the Medical Staff for Santa Clara Valley Healthcare. I believe you have our packet before you, including our credentials packet and several enterprise privilege sets. So I'm here to answer any questions. Otherwise, kindly appreciate your approval.
Thank you. Any public like to speak on this?
No requests on item 4.
Can you close that? Do I have any more questions or a motion?
Happy motion to approve?
Go ahead and second that as well. Let's take a vote.
Vice Chairperson Abekoga.
Aye.
Chairperson Lee.
Aye as well. Thank you,
Thank you.
Dr. Salmon.
Thank you.
That was easy. Number 5, considering the recommendations relating to federal and state health policy and budget landscape. Given how many things going on, this won't be easy. And to present the item today, we have Bert Margolin from Margolin Group. Good afternoon.
Health, is my microphone on?
Here we are.
Yeah,
that
there we are.
works. Thanks, Bert. Go ahead.
Since the last Health and Hospital Committee meeting, H.R. 1 became law, and we are now facing the harsh reality of the largest reduction in Medicaid funding in the history of the program. The Congressional Budget Office, CBO, has done an estimate of the impact on insured lives and is assessing that as many as 16 million people nationally will lose their coverage. It's a massive, massive threat to all the work that's been done over the last 10 years since the Affordable Care Act was passed. In your county health system report, you have details on the specifics of what was enacted, the work requirements, the limitations on the special payments called state-directed payments that are critical to the viability of public hospital systems, a new cap on provider fees that the state needs in order to draw down federal matching funds. All those things are detailed there. So I won't dwell on them in this verbal report. There are many challenges ahead of us, but of course it's important for us to realize that these cuts, many of these cuts and policy changes are deferred until either 2026, 2027, or 2028. The provider tax, for instance, doesn't kick in. The reduction in the provider tax doesn't kick in until October 28. The work requirements, October 26. The state-directed payments, January of 2028. Although there are other impacts, though, that are coming much sooner than the ones I just mentioned, and one in particular, which isn't technically in H.R. 1, it's really the absence of it in H.R. 1 that will create this problem for all of us, is the end of the enhanced premium tax credits for people on Covered California, on the exchange plans. They were first enacted as part of the American Rescue Plan and then extended through the Inflation Reduction Act. These are the, again, subsidies that allow people at a higher income level, still low income, but higher income level, to get to be able to afford the health insurance. So it's not technically in the bill, but again, if this bill was structured to actually strengthen the Medi-Cal program, the extension of these subsidies would have been there. They will produce a significant increase in premiums for people on the exchanges, not all of them, but for many of them, and large increases in out-of-pocket costs. The CBO estimates that in that earlier number of 16 million losing health insurance, 4 million alone are going to lose their coverage because of the loss of these enhanced tax credits. So it's a big impact, and that's going to happen at the end of this year. Of course, the delay on the implementation of the direct Medicaid cuts in H.R. 1 doesn't reduce in any way, shape, or form the urgency for counties, public hospital systems, and the state to pursue strategies to mitigate the damage. Those dates may seem a ways off. They're not very far off in governmental terms. They'll be here before we know it, and action is needed long before those cuts kick in to mitigate them. A prime example of early action, and really, in my view, it's a model for the state of California, is Santa Clara County's decision recently to move forward with a sales tax increase on the November ballot designed to help preserve critical services put at risk by H.R. 1. As far as the state's response to all this is concerned, there was speculation over the summer that there would be a special session in Sacramento and that the state would begin to grapple with these issues this summer. That did not happen. The special session was not called. And any discussion this August, as the session winds down, which we hoped would be about mitigating the damage. And again, there are legislators, and I know you met recently with many of them from the delegation, who are very concerned about this and talking about it and thinking about it. But the leadership of the legislature is focused on other questions, with reapportionment being perhaps the number one and dominant issue right now. The conventional wisdom, and these conventional wisdoms can change, is that the state response to H.R. 1 will be in next year's budget, deferring the issue really to Governor Newsom's last year in office. In the meantime, though, there's no shortage of work that needs to be done to analyze the impact of H.R. 1, develop strategies to mitigate the damage, and pursue opportunities like Santa Clara County's sales tax proposal. In order, though, to do this analytical work, it would be helpful, in fact, I would argue essential, that we have regulations and guidance from the federal government as to how these cuts are going to be implemented. It's one thing to say we're going to have work requirements. That's disturbing and concerning. But in order for us to work out a strategy to mitigate them and to implement them with the least amount of damage, we need to know what the rules are. And as of today, there have been no regulations proposed, no guidance letters sent. We expect they will come in the next few months. They'll begin to come in the next few months, and we will gain valuable insight into what we need to do to respond. Another threat that's out there that I just mentioned because we need to be aware of the threat environment is the prospect of a second reconciliation bill. Under the terms of the reconciliation process, this Congress is eligible to do a second bill in the fall. It's technically available to them. House Republicans over July have had discussions about a second reconciliation bill that would target Medicaid. Again, closed-door discussions have focused on reducing the federal matching rate for the expansion states. That was a key goal of the hardliners on this issue in the spring, and that was thankfully dropped from the Senate bill. We didn't have to deal with that, but the same forces that drove this historic cut in Medicaid are still targeting the program, and they have even worse ideas they'd like to pursue, which includes this reduction in the match for expansion states. So again, I think it's not likely to happen, but they're having meetings about it, and consultants are coming in. So given the way this administration has operated, we're at risk if we take these outlier threats and completely dismiss them, because they operate according to a set of norms and rules that are outside of the normal process that we've become accustomed to over the years. So important to know there's a second threat out there. Another possible threat, again, this maybe is more likely to be unveiled, is a regulation, not related directly to H.R. 1, but a regulation dealing with how states finance their state share of the Medicaid program, a regulation that would restrict our use of intergovernmental transfers, IGTs, and other state matching mechanisms. It isn't out there yet, but there are reports that it's being worked on, and we may have to contend with that in the coming months. The other big event that we're going to deal with in the next month, of course, is the federal budget, the annual drama over whether or not we get a government shutdown or not. There appears to be virtually no chance that a regular order full appropriations package will be approved. The House and Senate have both approved a few appropriation bills each, but they're very far apart. The Senate bills tend to be level funding. The House bills are reverting back to massive cuts, and there's not really a negotiation going on between the House and the Senate that's likely to produce an outcome that would allow for Democrats in the Senate, remember they're needed for the regular order, 60 votes, to be willing to join this process. So the choice for October 1 right now is government shutdown or continuing resolution with flat funding for an undetermined number of months. The Republican hardliners would like a full year CR with a full year of flat funding, but they'll settle for the longest CR they can get. There is a new and somewhat surprising tactic that's emerged that's really quite bizarre involving this battle over the budget, in that leaders of the Freedom Caucus, the most extreme group, have recently put forward the idea that attached to the continuing resolution with flat funding should be earmarks, the earmark package. You may recall that in past years, Republican fiscal conservatives, the hardliners, thought earmarks were corrupt, they were terrible, that they've since been restored, and they're referred to as community project funding. And now you have the most conservative members saying, let's bring back earmarks. Why? Because they want to use earmarks as a carrot to get Democrats and Republicans to agree to a CR, and the longest possible CR. So it's an unexpected strategy. We've come a long ways from the days when these same members called earmarks corrupt pork barrel, but here we are. A key health issue that remains unresolved for the county is still the deferral of the DISH cuts. Again, this is the federal program that was created to help hospitals deal with the burden of caring for an unusually large percentage of Medi-Cal and uninsured. It's the disproportionate share program. You have this burden. You should get extra federal money. When the Affordable Care Act was passed, this program was cut because we were expanding coverage, but the needs of hospitals, public hospitals in particular, continued, even with the Affordable Care Act. And every couple of years, the cuts get deferred. We were hoping they would have been deferred in H.R. 1, but they were not. They're still scheduled to take effect October 1, unless Congress acts. The old estimate of the county impact was a loss of $30 million per year as of a year or two ago. That's an old, out-of-date estimate. The number may be higher now. So that's a risk out there. But 3 points to keep in mind about DSH cuts. Number one, they still have strong bipartisan support. Both parties have historically supported deferring the cut, and there's no evidence of that changing. They're also linked to other so-called health extenders. These are other programs that will expire at the same time unless they're extended, and that includes community health center funding, the National Health Service Corps. They all have strong bipartisan support. And then the last point that's some reassurance is even if we get past October 1, which could happen given how dysfunctional the Congress is these days, it's possible that this can be fixed later in the year without any impact on the county. And that's because the DSH formula is complex. The county receives its DSH money in a deferred manner sometime into the following year, many, many months out, if not longer. So even if we lose on the October 1 deadline, I mean, technically the cut is in effect, it can still be fixed. Just want to be aware of that. Another issue, just to highlight before I finish, is that the state needs to renew its Medicaid waiver, the CalAIM waiver. This is our special agreement with the federal government that allows California to fund innovative programs that are cost-effective and good for patients. In the context of CalAIM, we have programs that help people stay out of emergency rooms and away from unnecessary hospitalizations. Enhanced care management is an example. Community support's another example. There's also substantial funding for behavioral health reform. California is in the midst of developing its extension proposal. The waiver expires on December 31, 2026. Again, it's a ways off, but we're dealing with a somewhat unfriendly federal environment, and I'm understating that. So the extension process is already underway. The state released a concept paper and is receiving comment this summer. And sometime early next year, we'll probably have the beginnings of a dialogue between the state and the federal government, and we'll have some sense of what our prospects are for getting our waiver extended. That completes my report. Happy to respond to any questions or comments you might have.
Yes, go ahead, James.
I just wanted to add a couple comments. While Bert did a great job kind of outlining the big categories of cuts that we're facing related to the Medicaid program in H.R. 1, I did want to clarify a couple things regarding timing. So it's absolutely consistent with our own projections that a lot of the biggest cuts come in a few years. But there are very immediate impacts from H.R. 1, including in the provider tax and in directed payments in ways that affect Santa Clara County starting this current fiscal year. One specific one is Proposition 35, which was passed by the voters in November of 2024, was an increase in the managed care tax. H.R. 1 froze and took that off the table. So that was money that the state had accounted for in this current fiscal year budget, and is money that we've accounted for in this current fiscal year budget. So while it's true that the increased ratcheting down of that mechanism doesn't kick in for a little bit, there's immediate impacts from the cuts in that category due to H.R. 1 that have already taken effect. Similarly, with respect to the directed payments, we would be expecting and had projected the expected increase in the amount of those payments due to regional joining our system, because we obviously are serving more patients. And again, because of the freeze in those under H.R. 1, that's an immediate impact on our budget this fiscal year, growing next fiscal year, even before the anticipated substantial cut off of current levels in those payments in the year following that. So I just wanted to clarify that point, because those are real impacts that we're facing immediately, in addition to all the ones coming in addition to the work rule related requirements. The other thing I would just say on the work rule related piece is what we have seen in the couple states that have piloted those types of initiatives is that those individuals for whom eligibility could not be automatically validated by the state systems, so I'm talking about in states like Georgia where they experimented with work rules, for individuals where they could automatically validate work information and history, things were smoother. But for individuals where they could not, it was exceedingly hard for those folks to jump through the process. One of the concerns that we have with the timeline here is that the state of California, these are statewide systems, these are not, even though the counties administer the eligibility processes, these are state data systems. The state has a very short runway to try to put those integrations in place to actually pull and automatically verify any of that information based on, as Bert pointed out, federal regulations that haven't even come out yet. And in its infinite wisdom, Congress allocated basically no money for that implementation. I think it was like 200 million nationwide, which is a joke, towards implementing those systems. So we are very concerned that California is not in a position, through no fault of its own, but given the timeline and given the lack of any funding, to even put those automatic systems in place in a way that's really going to work well. And we know from those other experiments, those failed experiments, that the consequences of not having those set up is that those other folks had a very difficult time validating coverage. So I just wanted to add those points. Otherwise, I think, Bert, you did an excellent job, and obviously this is been the subject of a lot of discussion at board meetings, and I've walked through what those projections mean for the county organization and for the services that we provide, and won't repeat that here.
Thank you very much, James. On that specific question on the directed payments that you said, when we acquire RMC, we basically did the math and thought that, oh, there'll be a projected increase, right, due to that acquisition. Now that this freeze is happening, can you roughly estimate how much of an impact would that be for just this year?
Paul, do you remember the exact number for this year?
It's approximately $50 million.
Yeah.
50?
50.
$50 million.
50, yes.
And that was a component, if you recall, when we put the numbers up at the special meeting, where we showed that there was a roughly 200+ million impact in the current fiscal year. That was one of the components of that.
And that's horrifying for this year, because HR 1's like many of those items, Bert, you mentioned, is still happening, phased out, and I think some of them.
Well, and that's why the amounts grow so significantly,
Exactly.
because there are things that are phased in. Some of the deepest cuts are phased in, and that's why when you saw our forecast, that number grew well over $1 billion as those phased in pieces come into effect. The other thing that really it's for CSFC more than this committee, but I think it's connected and it's worth mentioning, the SNAP-related impacts took effect immediately. So while we're waiting for federal and state guidance on the implementation, there was no delay in the work rule and other changes associated with the SNAP program. Those provisions of HR 1 were effective immediately, and there are fiscal impacts, administrative impacts associated with the whole food assistance program that affect us this current year.
Thank you. And Bert, just follow up on your, first of all, thank you so much for a very comprehensive presentation on the very, very large, is a big, I wouldn't call it beautiful, bill that we have here. And this ugliness is what we're dealing with right now and trying to mitigate these damages. You mentioned some of these are deferred to 26, 27, 28. You mentioned work requirement is not kicking until October 26. Is that correct?
It's kicking in October 26th. That's correct.
Okay, all right. And some have mentioned, I'm not sure if this is true, but that some of these dates are scheduled so that trying to play politics so that the pain will not happen until the election happens in November 26th? Is that some of the discussion that you're hearing?
Yes, people have talked about how some of these large cuts, and again, as Mr. Williams indicated, there's a lot that happens far before those dates, immediately in many cases, but the big impacts, the big dollars, seem to be timed to take effect after the midterms. That seems to be the pattern of the biggest cuts.
Okay, thank you, Bert. Oh, yes, Supervisor Abikoa, go ahead, please.
Thank you. Thank you so much for, it's very sobering, but I really appreciate all of the details. I think it's more for county executive, but in regards to like how this will all work, since you mentioned that the SNAP cuts will beginning immediately, so we'll see it in this current fiscal year. Will we be getting monthly reports on the losses that we expect, and then how are we planning to backfill? Is it I know often bring up that we don't have a lot of reserve funding, but yes.
Yeah, we will provide updates as we have updated information. So right now, we have the projection that we provided the board on August 7th. We don't have any additional information since then. We're dependent on the state, and our understanding is with respect to SNAP, the state is still waiting on the direction from the federal agencies on what to exactly implement. Then they'll roll that out. The state will then turn around and roll that out to counties. So as soon as we have something more concrete, we will, of course, share that with the board, but we don't have anything else more concrete other than HR 1 itself and our forecast and projections based on that, which we've provided. We will have to deal with these impacts probably at mid-year. We, of course, have a number of other lots of moving pieces at mid-year this year. So, that includes everything related to HR 1, but it also includes we had the negative Object 2 appropriation as part of the budget process. We had other related federal impacts as part of the budget process. We have, we have election-related costs, although there may be good news on that front due to the redistricting measure that might significantly offset that cost. So there's a lot of moving pieces for that. One of the steps that we have, of course, taken right away is we do have pretty hard hiring freeze now, and so that will help with some savings during the course of the year. But we're not really in a position quite yet at this point to identify more specific things. And as soon as that coalesces, we'll have to bring forward proposals and recommendations. So even though the SNAP piece legally is in effect under HR 1, it's not practically in effect quite yet because they haven't rolled that out. And as soon as they roll that out, we will provide that information.
Thank you. And then I just wanted to clarify, you mentioned earmarks are still a possibility, is that?
There's still a possibility because, again, the Freedom Caucus, who historically have been the strongest opponents of earmarks, have decided that this is the year to support them in order to get the flat funding continuing resolution through. So again, they've never been done before on a continuing resolution. They're normally attached to the appropriation bills, the regular appropriation bills as projects, but this is a twist in the story. And again, Democrats and Republicans have earmark requests in. They're now called community project funding items. And it could happen this year because of this Freedom Caucus reversal. Might happen.
So, and I guess going to our team, we met with IGR, but I believe we do have some requests in.
We do, yeah. We always.
Should we be looking at more?
Well, so they have parameters around the requests.
Yes,
and they're pretty.
In line of.
Yeah, they're very limited. So what they tend to want to fund are short-term, small capital or pilot program investments. Maybe you could think of it as the federal version of the inventory process, right? So we always work with all of our 4 members of Congress who represent Santa Clara County.
Yes.
And we do submit items for consideration. We've been awarded some things, and actually every year at least a few things, some really innovative projects, but it's not going to address our broader
No,
fiscal
but-
needs, but we're part of the mix.
Okay.
We're part of those requests, and we have gotten some capital project support for initiatives. We've also served as a fiscal agent for some community entities in the past as well.
Great. Thank you. Thank you, President.
Thank you. Jess, do you have any public who would like to speak on this item?
I have no requests for item 5A.
Okay.
So we've also covered 5B effectively.
I believe we have 5A and 5B covered already. So
Thank
let's do both. And let's see if we could, do we need a motion? Yeah, I guess we should have a motion to receive the verbal report. And Vice Chair, would you like to make the motion
Make a motion to approve or accept the reports.
for 5A and 5B? The
For
report
5A
from
and
both
B, yes.
Margolin Group and from the Santa Clara Valley Healthcare. And I'll
Thank-
second that.
Thank you. Vice Chairperson Nabekoga?
Aye.
Chairperson Lee?
Aye as well.
Thank you.
Report's been received. Thank you very much.
Thank you.
Yep. Please keep us posted. Number 6 is to receive the report also from Santa Clara Valley Healthcare relating to the mobile dental services for veterans.
Thank you, Chair Lee. I will go ahead and handle this item. As you well know, something that you've been involved in, as well as the rest of the board. In October of 2024, we started the Mobile Dental Service Program in partnership with the Veterans Services Office. As you well know, it offers screenings, cleanings, x-rays, extractions, and preventive care. We also, as you well know, provide this service currently under contract 1 day a month, and we also sponsor and support the 3-day stand-down event in October. To date, we have served through that program in partnership with the VSO 375 veterans, providing about 690 visit encounters. 121 of those veterans received follow-up care and benefit enrollment support from Santa Clara Valley Healthcare through our referral process. In addition, through that effort, we've also supported these veterans in making referrals for behavioral health services, substance abuse support, and also housing support. We are and will continue to partner with the VSO to ensure that we have a sustainable program. As you well know, the importance of making sure that individuals identified during these screening events are referred into the health system for ongoing care and support within our system, because we have fixed dental facilities and sites. So our desire is to make sure they get connected into the system for their ongoing care needs. So this program was really set up to provide for the outreach and engagement, and then bring them into our health system for ongoing care and support. With that being said, I'm happy to answer any questions.
Yes, thank you very much, Paul. Before we ask any questions, is anybody in the public who would like to speak on this item? Jess?
I do have one request on Zoom.
Okay, let's do 2 minutes on that.
Thank you. We'll close the queue. Our speaker on Zoom is Ken Horowitz. You'll have 2 minutes. Please go ahead.
Good afternoon. This is Dr. Ken Horowitz from the Health Advisory Commission. And this item was brought up, and I spoke on this item as well back a number of months ago when there was a cut in the mobile van services from $360,000 to $180,000. And I raised this concern as well as Supervisor Lee. But I'm really happy to hear and want to compliment Mr. Lorenz and his dental team, because they have stepped up to the plate, and they have agreed to take on these veterans who are in great need of dental care. As I pointed out, unless you're 100% disabled, which basically means you've been wounded in combat, you don't get dental benefits from the VA. And so there are certainly many, many vets out there that are in need of dental care. And so I'm glad that Santa Clara Valley Healthcare is going to step up and see these vets. And I want to compliment the team out there. Thank you very much for your time.
And that concludes public comment.
Thank you very much. And let's see, I don't see lights from my vice chair. Vice Chair, do you have questions about this issue?
Oh, yes, just a
Please.
quick question. And thank you for the report, and it's really impressive to see the success of the program. I was wondering if you could share the issue around Medi-Cal eligibility and what the barrier is to preventing the mobile program from becoming a Medi-Cal enrolled provider.
Thank you, Supervisor Abacogas. So as you well know, the mobile dental program, to your point, has the ability, if they so choose, to enroll into Medi-Cal program to seek reimbursement for these types of preventive services and screenings and so forth. I cannot speak for them, but what I do know is that from my understanding, the percentage of actual individuals that would actually qualify for Medi-Cal, and it's actually playing out in some of the numbers, aren't as high as that they would expect, and that's why they're being referred into our system for ongoing, enrollment and evaluation. I think the other part of it was that in their analysis, as I understand it, that they may not meet the income threshold to qualify given certain other asset test requirements and so forth. But that's something that we will continue to explore with them, encourage their interest in potentially becoming a Medi-Cal provider.
And then how are you tracking the long-term health outcomes of the folks who are receiving our dental care?
That's a really good question. I think because we've been so focused on trying to establish the program and so forth, I think I could get back to you in terms of what the overall goals and how we're measuring up to them.
Okay,
But I would
nice.
share with you is that there's immediate return on that investment relative to actually treating their acute
care.
needs. We've also identified, as I reported, other needs that these veterans have
Yes.
identified relative to housing, substance abuse, and we're referring them into service. But I think it would be good for us to establish some longer-term goals if we continue with this program.
And then in addition that they get into the system to receive other physical health care, is that right?
Yes, so part of the referral process includes making sure that they have an established medical home.
Okay.
Most veterans do. If they don't, we will help facilitate that
Okay,
and ensure that they receive the whole person care approach relative to their healthcare needs.
great. Thank you very much. Thank you, President. Happy to make a motion to accept the report.
Thank you very much, and I'll, of course, second that. First, I just want to say that this report certainly brings me a lot of happiness to see that the SCVH and VSO are also working well together to implement this program. Many veterans, as we know, have not been properly served, or some being forgotten, and we are certainly working hard to try to address their needs. I've said this before, and it bears repeating, that the VA really does not cover most veterans' dental services. The eligibility is very, very harsh, and that is veterans need to have a complete 100% total disability rating in order to obtain VA's coverage for dental care. And in order to get the 100% disability rating is certainly very difficult, and most people do have a disability rating, but not the 100%. So most veterans, in other words, would not get any VA support. And so again, so this is something I want to highlight, and that's where we need to step in, number one. Number two is, it really is not just a dental program, right? It really is also an in-person touch to trusted referrals to the other services that a county offers, like the medical, behavioral health, substance abuse detox program, and even housing, right? And also connecting them to the VA. For whatever reason they have not been connected to VA, there's also no way for us to do that. So I just want to say, SAVH and VSO, thank you very much for your joint commitment to improve the referral services, the process, communication, and desire to support our vulnerable veterans to get access to do not just dental services, but coordinate the necessary follow-up, and hopefully to get them to future care through our other systems and go through the red tape and forms to get qualified. And I also want to look forward to see the data from the survey. The VSO will be administering to gather feedback about the mobile dental program to see the respondents. And from what I've heard anecdotally, is a program that is really, really much appreciated. Now, one question I do have left is, how does the SCVH patient access team get involved with the veterans served through the mobile dental to provide assistance with the health insurance program enrollment? And what does this referral process look like?
Thank you, Supervisor Lee. So it's pretty straightforward. At the event, the appropriate paperwork is filled out with respect to a referral for both services, but also for financial review and eligibility. That referral form is sent to the dental program in-house relative to service needs in terms of follow-up care. And then it's also provided to our financial counselors to also follow up with the patient to determine eligibility and support for other healthcare services within our system, including potential enrollment in programs, including our self-discount program,
Right.
based on income.
Right, because right now, this is not technically a reimbursable Medi-Cal type services yet, but this ongoing investment we're doing right now is to help get the veterans the access to these potential eligible health insurance program in the future. That would, of course, covered by Medi-Cal or Cover California or the county's health access program, while helping them to get access to VA benefits, right, that they're entitled to receive. So this is really a bit of a, not just dental, but a referral, which I thought is really exciting. Now, we know we are, just like what we said by Ms. McGowan earlier, we are facing some very serious budget financial constraints. And since this funding is coming from our general fund, my question here is there a reason why we can't open up this program to other private philanthropic opportunities and donations from our community? Because as far as I know, there are many organizations, people that would like to help and are more generous when it comes to supporting veterans in terms of donations. Thinking about how this program is not Medi-Cal reimbursable, I'm hoping the administration can also look into the other sources of funding to help make sure this program could be maintained in the future.
Thank you, Supervisor. That's a wonderful idea. I do have a follow-up item to speak to our foundation to see what they can do to raise money specifically for this cause to offset the general fund contribution. Because to your point, there are probably a number of people and businesses in our community that will support our veterans. So,
Right.
so that's something we will follow up on.
Thank you so much. Yeah, we've certainly, our county has pushed forward and VTA supported having the $1 ride for VTA buses and light rail all the way to November, for example. That's working quite well right now. We've had free rides for veterans, like free taxi rides to their appointments in the VA hospitals and whatnot. So these are various things our county has done, working to provide. So I'm hoping that we could get more community folks to join in to continue to make sure that this very important program will be continued, not facing the cuts that we will be seeing for sure to come. Okay, all right, and that's all I have. If there are no further comments on this, let's go take the vote.
Vice Chairperson Abe-Kokan.
Aye.
Chairperson Lee.
Yeah, I as well. Thank you.
Thank you.
Moving on to item number 7, which is the monthly report from Veteran Services to Staff Sergeant Fox Suicide Prevention Grant Program.
Hello there. My name is Stephen Fisher. I'm the management analyst with the Veteran Services Office here to present this month. Darlene Escalante, our director, is not available today. Give me 1 second here. We do have a report to present.
Thank you.
All right, presentation should be live. So as we get started again, just as a reminder, the program we're discussing is the Staff Sergeant Gordon Fox Suicide Prevention Grant Program, known as the SSG Fox SPGP. This program, since we presented last at the previous meeting, or the previous committee, has now been fully staffed with 2 social workers. We have completed and submitted our request for both additional funding as well as an extension. The extension request was submitted through June 21st of 2026 and will provide us with additional time to utilize existing funds. The renewal application was submitted, and if granted, will provide additional funding once current funds are expended. At the time of authoring this report, 35 unique individuals had been screened, where screening in this case is assessments that are non-clinical in nature and identify an individual's risk level for mental health challenges or suicide prevention or suicide risk. And at the time, 11 individuals had been deemed eligible, meaning that they are found to be at risk and are veteran status. More broadly, like we said, 2 social workers were brought on. We did screen more than the initial target we had provided for ourselves, screening 35 as opposed to 30. However, only 11 of the veterans that were screened were deemed eligible and enrolled, as opposed to the target of 15. We do believe that we're addressing this and making sure with more coordinated and targeted, and I can provide an update on that when we get to some of the more specific metrics. Outreach, we did target making 3 events per week that the social workers will attend, either individually or as a combo, and we've been able to meet that goal with 19 different events attended at the time of writing. And both the extension request was submitted as well as the program renewal requests. In terms of staffing, so we're both onboarded with the second beginning services on July 7th. We have begun the process of requesting the transition from extra help to permanent staffing. That will be term limited through the duration of the grant program. As of right now, we have approval for extra help through September 30th, which was the original end date. However, as noted, we have been granted an extension for the grant program and are working with HR to continue providing services, not have a gap due to procedural needs. The screening that we performed is just looking for anybody who is at risk, and then eligibility is noted. And then an individual is enrolled and receiving case management and services through the program. At the time, as of right now, we have screened over 50 individuals, and the number who have been deemed eligible and enrolled is over 20. As noted, and again, this is slightly out of date, but we did have 35, of whom 24 were found not eligible. All of these individuals are referred to appropriate services either within the Veteran Services Office, either to our Prop 63 mental health grant for additional resources and information, to veteran service representatives to identify if there are any VA claims, to partners working within either the hospital system or behavioral health as appropriate, just to ensure that they're accessing all benefits, as well as within social services to DEBS, DFCS, as well as DOS for those who need support as older adults. When we talk about case management, this has been identified as primarily taking an individual, identifying where they have their needs are, and doing a collaborative interview with the individual to find mutually agreed upon goals. These are identifying a treatment plan, and will identify, hey, here are your current areas of need. How can we assist you in meeting those, whether that is through direct interaction, referrals to outside groups, or independent goals that the veteran will take on themselves. This includes meeting with a social worker on at minimum a monthly cadence, as well as providing opportunity to check in on all resources that have been referred out to and identify progress at that time. Quarterly, the social workers will perform reassessments with the similar screenings to both identify progress and continue eligibility for the program. Here are kind of some of the highlights of the multiple outreach events that were attended by the social workers through June and July. A particular highlight was taking part in the unhoused veteran outreach, known as the VA Surge, the Women's Veterans Day in June, as well as attending support through PGA the PGA Hope, which is a veteran support program through PGA, as well as the Veteran Appreciation Lunch hosted at the Milpitas Community Center. And looking at some of the specific needs, this is from Fox categorizes the specific needs under various categories. And the one I wanted to point out here is the fact that of the 35 individuals who were screened, it's very clear that well-being was the most commonly cited figure as needing support, distantly followed by medical. I also note that of the 11 individuals who were deemed as being eligible at time of screening at this report, all 11 did report well-being as an area of need. I know this is a broad category, but identifying that the people in our community who are seeking support, who are looking for help, they're looking for help, and it's just a general well-being and various terminology within that, but people are just finding it difficult in the current time, as has been already discussed in this meeting. To support this, we are working VSO and the Behavioral Health Services Department closely. We are meeting bi-monthly, so every other week here, and I've been engaging with data sharing to identify where within the community and within the county are veterans in need. Through this, we've identified that there are over 100 unique veterans who received services between beginning of last calendar year through July of this year. Identifying is figuring out where are these veterans, how are they accessing help, and what can we do to ensure that they're accessing all benefits to which they are eligible to receive, whether that's from behavioral health, social services, or the VA. And in addition, VSO is continuing to refer veterans to behavioral services based on their eligibility for behavioral health programs. Typically, these are those who are the most at need and trying to prevent anybody from needing to go to a hospital and making sure that they get support before reaching a crisis stage. The VA, the program itself, Staff Sergeant Fox, has been renewed through funding through September 30th of 2026, so the end of next federal fiscal year. There are multiple bills currently moving through Congress. However, as of right today, there is no hard update provided by the Fox team. We are operating under the assumption that our approved funding extension request will be confirmed and that we will be able to continue providing services through June 21st of 2026 with the goal and intent to receive additional funding through next federal fiscal year that will then again potentially be extended beyond September 30th of 2026. In the meantime, VSO is exploring additional options to continue providing support to those in need with the understanding that as of right now, we have limited availability of funds and we don't want to leave people out high and dry at the time when they're most at need solely because a budget line item went to zero. And here is a general timeline, just noting that we were able to confirm that we had 11 veterans enrolled with 35 screened. Moving forward, we do hope to vastly increase our number of screening as well as enrollees, with a target by October when the program will be fully implemented, where we're screening 50 veterans per month, 15 of those ideally being enrolled, which will meet the program's overall target of 100 veterans, unique veterans enrolled throughout the lifetime of the program, and attending 20 outreach events, which will be an average of 5 per week, or 2 to 3 per veteran, per social worker working within the program. Thank you for your time, and are there any questions?
Thank you. First, any speaker on this one?
Double checking item 7. I have no request to speak.
Okay, yes, Vice Chair, go ahead.
Thank you, President. And thank you so much for the presentation. It's great to see that you're fully staffed and expanding rapidly. I wanted, and still learning all the nuances and details of these programs, but when you mention targeted outreach, does that mean targeted to the veteran community, or is there an even more specific target? Like, are there actually individuals you're aware of that you're trying to reach?
So a combination of the two. The Veteran Service Office, we do engage in routine continuous outreach, both within kind of North County as well as targeted South County at the Gilroy location at the Gilroy Veterans Hall.
Okay.
Trying to reach veterans in general. On top of that, we are working with the VA Palo Alto's suicide prevention. They have a suicide prevention team.
Okay.
And we're working closely with them to try to identify veterans who are not yet affiliated with the VA. And trying to combine that with the data from behavioral health to figure out, hey, who are the individuals that are most likely to not yet be receiving full benefits? And then how do we find them physically or by email contact, whatever we can do to outreach them. Okay. So that's our targeted outreach, is a hybrid of both just targeting within the veteran community and then trying to be as specific as we can.
Great. And then I know the goal is 100, but do you have a overall number of what the actual potential need is?
We are not 100% aware of the total need. When we were I was doing the report drafting and authorship and trying to do data finding. One of the items that we used as a tentative baseline is identifying through our Proposition 63 mental health services program, which is currently in its fourth year of implementation. We're identifying that of that, nearly 150 individuals per year, sorry, I'm pulling the numbers from memory here, are expressing support and needs. And of those, we were just reviewing the data and identifying that that's likely where we found that of those who were supported through Proposition 63, about 100 or so had self-reported concerns with suicide or other serious mental health concerns, which is where we generated that number.
Okay, great. And then having heard the previous item, I'm just wondering, like, these are two programs targeted towards veterans. Like, where's the overlap, or is there overlap with the outreach?
I could probably give another full report on all of that. The initial justification for the mobile dental program came through the hard work done through the Proposition 63 to identify dental as an outstanding need that was not being met for the veterans who were experiencing mental health, and through the connection between if somebody's experiencing severe chronic dental pain, that's not going to help you with anything else, which led to the partnership beginning.
So if someone shows up to the dental clinic, is there some kind of screening that's done where if they need behavioral health services, they could be referred to this program?
So when an individual is first entering into our office, so at the time when they would be saying, hey, I'm interested in attending the mobile dental clinic on the veteran services side, the individual who is receiving that call will identify have they gone through the screening process yet internally. If not, they will be provided with the information and referred over as much as we can. And then when individuals are on site, physically, we are making sure that they have that opportunity to meet with the social worker.
Great. Thank you so much. And happy to move the acceptance of this report. Thank you.
Yes, I'll go and second that as well. Well, first of all, thank you for this report. And it's the best news, of course, is having those two members being finally hired and staffed and is moving forward. So that's great news. Looks like based on the data, we are certainly trending in the right direction for this program. Now, for the 113 veterans being served, are any of them are still at risk for suicide being referred to this new program at this point?
So I don't have the specific information on that. Like I said, we're just beginning the process, and that was kind of the first from the STAR process of it gating the data communication. One of the challenges that we are working with behavioral health on actively is the concerns over data privacy. As our program is non-clinical in nature, we do want to make sure that we are respecting these individuals' privacy rights. And what the current goal is working on ensuring that individuals who are being served by behavioral health services are provided with the knowledge of our program and can be provided a pathway or a referral process as well, similar to the Medi-Cal cost avoidance program where individuals applying for Medicaid who do identify as veterans are automatically referred over.
Okay. Now, the report also states that the VSO aims to finalize the program development in the next couple of months. And I certainly look forward to this continued progress, and we'll reassess that, right, when it comes back to us at the October HXC meeting here. One thing I do want to mention is, I mean, clearly the enrollment percentage seems to be quite low compared to the folks who are being screened. What exactly do you think are the hoops and eligibility that cause so many folks to not become eligible?
I wish that I had our social workers here to answer that better than me. For my understanding and through the data review, one of the biggest concerns is individuals, currently we're focusing on ensuring that anybody who identifies any self-risk is screened. So this is identifying anybody who is submitting a benefit that might be related to previous mental health concerns or conditions, anybody who, which includes those filing for PTSD or similar concerns for their time in service. It also is just an intent to just get the word out and highly encouraging individuals who are even at all interested to go through the screening, which does result in a screening process that is higher than necessarily intended. As part of that, we do not have a maximum screening goal. We're not limited to only supporting 25 people per week or anything. And our goal is that as we continue, Supervisor Abekoga's statement of really focusing our outreach and marketing to identify those who are most at risk so we can connect them with the screening and then proceed towards eligibility.
Right, because well, the number one goal of this is to save lives, but two is really providing the path of referral to the various services that these folks are eligible to that's not being connected as well, correct?
Yes,
Like
sir.
we talk about the dental program, similar objective. Now, let me ask you this. For those who were deemed non-eligible for this type of services that's mentioned, are there any type of follow-up with them after the eligibility is like, oh, no, you're not eligible, but do we also follow up with them to see how they're doing?
So that's the task that we're working on as part of the program in implementation and full development. Through the Fox program, the Fox program does not track individuals who are deemed as ineligible. However, as best of continuity of care and ensuring that we are following with individuals, we are working as a department to develop that tracking. However, at this time, I don't have any hard figures or numbers on that to share.
I think it's important, right? That they've been screened, they've started coming to the program. Given the news that, oh, I'm sorry, you're ineligible, let's not let them hang because of the issues of, all the red tapes. They still need help.
Yes.
And when I look at the service needs, right? So, for example, on the well-being, out of those who came through the system, there are 30 being screened. 11 has been eligible, but then there are 19 that's not eligible, just on the issue of well-being. And even on the medical side, right, more than half, 8 out of 15 was not eligible. The one I'm surprised is SUD, right, substance abuse treatment. Out of the 3 people, there's 1 that's considered knowledgeable. So I would really want to make sure those type of folks on the issues that is completely in our bailiwick as a county, that there's some type of follow-up to make sure that these folks are still okay and to connect them to services. So clearly, there's still a gap.
Yes, sir. And then just to confirm, for anybody who is screened as found not eligible, it means that they're specifically not eligible due to not screening high on a suicide risk assessment.
Right.
We do ensure that all individuals are immediately referred to our existing Prop 63 program. We do follow up with them through that. I just don't have those figures specifically linked back to this. However, we can include that in future reports.
Please, yeah. I think that could be very helpful to make sure that we basically want people to fall through the cracks of different programs.
Absolutely.
Yeah, which we certainly have seen since we have so many programs.
Yeah, and the worst would be somebody screens is deemed ineligible and then comes back a month later now being eligible.
Right. Okay, so knock on wood, none of the folks we have screened has actually later on committed suicide, correct?
Not as of this time.
Good. Let's keep it that way.
I hope so as well. We don't want to leave anybody behind.
Right, exactly. Right. Okay, thank you very much for the report. And I've got a motion, I've got a second. Let's go take a vote.
Supervisor, excuse me, Vice Chairperson Abekoga?
Aye.
Chairperson Lee?
Aye as well. Thank you.
Thank you.
Thank you very much, Ms. Fisher. Moving to item number 8, which is the report from Public Health Department relating to the state of county's health. And I believe we have Sarah Rudman, Dr. Sarah Rudman, our Public Health Officer. Good afternoon.
That's right. Thank you so much, Mr. Chairperson, Madam Vice Chair. I'm very pleased to present today a report that really rounds up why we exist, why your county has a public health department to support the broad suite of work that rests at the county and across the county. And I will frame that work first by sharing a metaphor that we love to torture in the public health department about a stream. And if you imagine that a devoted county employee sees somebody drowning, running downstream, and jumps in and saves them, and then does so again and again each time somebody is struggling in that stream, the goal of your public health department is to look upstream and say, is there a bridge that's broken? Is there a safer path through the water we need for people? Are there swimming lessons folks need? What do you need upstream to make sure that our people are not suffering? And so what I'll share today will be briefly the furthest downstream that we look at, mortality data, to help us understand what the people at Santa Clara County need to be healthy, and then touch on what we do upstream to try to keep it that way. But outside of just the public health department, the county itself acts at every level laid out here. So I think most notably, the county runs the second largest healthcare delivery system, public healthcare delivery system in California that treats people at the point they are ill or need primary care to keep them safe and alive. But the county, you've heard in other presentations today, works to improve living conditions, risk behaviors, mental health, and the core social inequities that lead to the kinds of downstream illness and injury we hope to prevent before we need to treat it. What I'll also mention today is some of the threats and risks to the work we are already doing and the needs our county is already experiencing in the current environment, many of which we've also touched on today. So to start you off with just the very first marker, and really the most powerful one to me, is infant death rates. What could be, a more important bottom line than making sure that people survive their infancy and that families survive that first year of parenthood. And here in Santa Clara County, we mimic a national trend of seeing really stark disparities by race and ethnicity when it comes to infant mortality, such that our African and African ancestry community members experience double the rate of infant death than the next group, our Latino community members, who also experience a significant disparity compared to white and Asian and Pacific Islander communities. So you'll see in a moment how we have some targeted activities to try to enhance infant survival and parental and pregnancy well-being to offset this trend. But as you'll see throughout the rest of the data I share, overall Santa Clara County looks very healthy. When you don't break it down to understand who's vulnerable and who's thriving, but just look at averages, we have an incredibly healthy county compared to all of California and in fact the entire nation. And you see that here too, that our average rate of infant mortality here is much better than the US average. Likewise, when we look at overall life expectancy, the Santa Clara County average is one of the highest in California and in the nation. And again, when you look by race and ethnicity, you see stark disparities, again, with a much lower life expectancy for African ancestry individuals, followed by Latino and white community members, and then finally with the highest rate among Asian and Pacific Islanders. However, and I know Supervisor Abekoga has asked for some really important deep dives to understand what is behind that Asian moniker that we know is so limiting to understanding who we are as a community and what's really happening. When you start to break down that Asian group into subgroups and communities, you see really stark disparities. So for example, our Vietnamese and our Filipino community members have life expectancies that look much closer to the Latino and white communities than other Asian subgroups, including Chinese American, for example. So much more to be said there. The other thing I think is really important to look at is the trend over time. Now here what stands out to me most is that we had been heading, and sort of the arc of history, and including moving towards justice, has been moving towards longer life expectancy, moving towards longevity. But we as a community, as a nation, and as a globe experienced a setback when COVID hit us all in 2020. And that's why you see that big drop-off and a disparate drop-off. Just as we've talked many times in this body about how different groups were hit differently by COVID and by all of the harms of the way the nation and the county changed during that time, groups were not hit the same way, and therefore their overall life expectancy was impacted differently. And we have yet to recover that loss in life expectancy. In addition, I think really important to highlight that race and ethnicity is not the only major marker of disparities by when you look at mortality in the county. Geography also really matters. Now, there's a lot more to be said when we have the ability to look all the way down to the census tract level. But even at the zip code level, you can see these lighter areas have lower life expectancy, significantly so. And again, I'll give credit to Supervisor Abekoga, who I've heard before say, don't forget about Mountain View. When we look about the areas in Santa Clara County that have outsized need and need for support, you'll see that there is that one zip code standing out near downtown Mountain View that looks much more like San Jose and South County than it does the rest of North County. And I think some of the details of what lies behind these geographic differences is incredibly complex. A piece of it is tied to race and ethnicity, but there are many components that are unrelated. Now, to look at what are the top causes of death in Santa Clara County, and therefore where do we need to be acting to make the greatest difference, we, like many other very healthy parts of the country, see cancer as the top leading cause of death, followed by heart disease. And then cerebrovascular disease really means stroke and similar illnesses, unintentional injuries, and then Alzheimer's disease and other dementia. This is similar to the rest of the country, although the average for the country sees heart disease as a greater killer than cancer. I will highlight this is the first year since 2020 when COVID has not been a top 5 cause of death. What I also will flag that even though cancer and heart disease are greater, more frequent causes of death in Santa Clara County, the causes that cause the most life years lost, because usually this leads to the death of a younger person, a healthier person, are unintentional injuries, and that includes drug overdose. So you'll also hear in a moment about the work we do there. And then finally, we care deeply about what are causing the most disparate deaths. What are the greatest levels of unfairness in why and when and how people die? So for example, we know that overdose deaths are 10 times as likely in African ancestry residents as in Asian residents. That alcohol-related deaths are 9 times as likely in Latino residents, and homicide deaths are 8 times as likely in African ancestry residents. So next, on, I think, sort of the most disheartening note, especially given certainly everyone on this dais who has devoted our careers to the health and wellness of our community here in Santa Clara County, and frankly, anyone who is sitting here right now or bothers to tune in for a 3-hour public meeting about health cares deeply about the health of the community. And almost all of the work we are doing is at outsized risk right now. And if you look at every level of this stream, we are working to make safer. There are new risks to us. I feel quite certain that the single greatest risk is the drastic changes we've seen as a result from HR 1. And the reason for that is twofold. One is that we, as a county, have both a moral imperative but also a legal requirement to be the safety net, the healthcare provider for everyone in the county who has nowhere else to go, including people who may have other places to go but who receive certain specialty healthcare like burn care or trauma care in our top-tier medical system. And without the resources to pull people out of the stream who are drowning, we cannot ethically resource anything else. We can't pause long enough to build a bridge when people are drowning. And so not only does the billion-dollar hit to our safety net healthcare system jeopardize everything we do to save lives, but that person who's drowning is somebody's brother, parent, caregiver, friend, spouse, and the loss of that person affects every step upstream. In addition to that, for example, we discussed also today that some of the changes with HR 1 affect SNAP and SNAP eligibility. And unfortunately, we are being asked to use public resources to prove that somebody is working hard enough to be worthy of care instead of using those resources to provide the care itself. And so when you look at this upstream image, access to food is a core step to making sure the rest of the county is healthy. You can't do violence prevention, you can't do overdose prevention, you can't get someone to wear a bike helmet if they are hungry. And so the threats to our food system, the threats to our mental health that we are seeing in some of the immigration changes, the threats to vaccine access from some of the changes to the scientific system and the withdrawing of scientific accuracy to the policies being made, each of these steps at which we intervene are frankly, in many ways, moving in the wrong direction. That said, here in Santa Clara County, I will just give a handful of examples of the work we're doing to offset these incredible risks, knowing that this is a drop in the bucket of what happens in the public health department. So as I said, we try to prioritize our work focusing on what are those greatest risks, what are the most powerful interventions for these causes of death, harm, and disparities. So for example, we operate the Women, Infants, and Children's Program, a supplemental nutrition program focused both on that core need of healthy food that prevents everything from cancer to heart disease to diabetes, and that core upstream element of pregnancy and birth and early childhood. We operate the Black Infant Health Program that works to explicitly repair the disparity we saw in Black infant and maternal health outcomes, and a perinatal equity initiative that's been championed by the county to work at a greater policy level and fill in some of the gaps of that Black Infant Health Program. When it comes to the offsetting cancer and heart disease as major causes of death, we do important work in substance use prevention with our partners in the behavioral health group and healthcare delivery as well, but really looking how far upstream can we go to make it harder for somebody to ever smoke that first cigarette, ever have that first alcoholic drink, to prevent them from the liver cancer, the lung cancer, the heart disease that we know is related. We also work with our cities as partners to make sure that where those cities can, especially in the neighborhoods most impacted, change policy to give people an opportunity for health, that they have the information and support they need to do so. And then we work across the spectrum with food insecurity and access to the kinds of nutrition that helps people decrease cancer, decrease Alzheimer's disease, decrease heart disease. We also work in our environmental health division in offsetting exposures to other harmful substances that are related to cancer in particular, such as our hazardous materials and site mitigation programs. And then we also focus, as I was saying, on that greatest threat to disparate deaths and life years lost, which is the accidental deaths category, which includes violence, overdose, traffic deaths, et cetera. So we have an entire violence prevention group. We have nurse home visitation programs that help parents keep their children safer. We operate a Safe Routes to School program that helps people commute more safely. We offer bicycle helmets, car seats, and overall skills to help communities identify the greatest needs for safety. We also work, as we've spoken in detail here, in great deal about offsetting the incredibly disparate and until very recently rising risk of overdose death to make sure that people survive their substance use to the point of recovery. So with that, I'll stop. You can imagine I could go on much longer about what we do and why it matters, but I'll be very happy to take any questions. Thank you.
Thank you very much, Dr. Redmond. That was a very comprehensive report and very sobering information. But let's see if there's any public who'd like to speak on this.
No one in chambers, no one on Zoom for item 8.
That's surprising. Okay, yes, Vice Chair, do you have any questions on motion? Go ahead.
Thank you, Chair. And thank you so much, Dr. Redmond, for this very clear, informative, data-driven picture of our community's health. I see that, and rightfully so, that there's a focus on targeted intervention, and I was hoping you could share some of the outcomes we've seen from the work we're doing in harm reduction or overdose prevention, and especially in the communities with the highest disparities.
Sure, thank you. Now, the epidemiologist in me wants to give you a 1-hour answer to that question. I think most importantly, whenever we answer those important evaluation questions, we want to make that information available to the public. So some of what I'll flag now is available in much more detail online. We did a comprehensive community needs assessment, and we also report to this body annually, I think usually in January, a harm reduction report that details all of the progress we're making, where we see changes in need, and what new strategies we're employing around harm reduction. So those reports are all in detail on the Public Health Department website. But I think I'm glad you asked that particular example because harm reduction and overdose prevention is an area where we get incredible value for the work we do, and incredible ability to count lives saved. We know just last year we had over 650 near deaths reversed by Narcan distributed just by the Public Health Department, and we are only one of the people in the county distributing Narcan. A big bulk of the work comes from my partners and sitting on either side of me. So we know that it's not enough to wait until somebody is downstream drowning. We don't wait till somebody is overdosing to intervene. We use that opportunity where we are getting Narcan out into the field to help reverse those overdoses, and then make sure we're getting somebody into the treatment they need, and working with our partners there. And we have likewise seen a dramatic increase in our ability to connect people to the treatment they need in the way they need it recently. Now, I don't want to steal the thunder of any of my colleagues, but I know that there are also incredible improvements coming in our ability to connect people to exactly that treatment resource that they ultimately need. That upstream intervention is coming imminently as well.
Now, just add on that point, I think there'll be a lot covered at the Behavioral Health Quarterly Report on that front on Tuesday at the board meeting.
Okay, great. Thank you. I was, in regards to life expectancy, and we see the gap between the African community and the Asian community, what are some of the strategies that we're employing to address the shorter life expectancy of those in the African community?
I mean, there are many, and again, not just employed by me, but really every agency in the county to some extent is part of that work. I think unique to the public health department, we have programs like the Black Infant Health Program, or given the very drastic disparity that leads to overdose deaths in African ancestry communities, or we know that similarly gun violence deaths in African ancestry communities are part of the major drivers for that disparity.
Okay.
And so
I
that's
was
why we
gonna
have
ask that.
targeted programs. For example, we have a specific partnership with Roots Clinic, understanding the drivers of overdose in African and African ancestry community members, and creating an Afrocentric model to make sure it really fits the needs of the community to help understand why folks are using drugs and ultimately dying from them. Likewise, in many of our violence prevention work, we are explicitly looking for African ancestry community groups, community leaders to tell us what are going to be the most impactful responses to that disparity we see, and making sure we are in the communities or supporting agencies that are in the communities to do that work. And I think we apply that same lens when, I think actually the Latino Health Assessment is a great example of when we understand a particular group is being disproportionately impacted by a particular harm, asking that community to help us understand what's behind that, and then what activities are going to make the greatest difference.
If I could just add one thing on this point, I think this is where what's happening at the national level is so concerning. There is a real effort to erase even this data, and to then not be able to see. And if you look at the Santa Clara County average data, not just geographically, but by ethnicity, if you just look at the overall averages, we're doing so much better than any county in the country, really. We're one of the healthiest counties in the entire United States. And it's only when you really break that information down that you actually start seeing areas where there's real room for improvement. And so on the one hand, you could say, well, even for the African American ancestry community in Santa Clara County, we're doing better than the national average life expectancy generically, right? And that's a great thing. But you see those disparities and you see them vividly. And one of the things that this board has done in the adoption of the most recent budget is actually ensure that we are locally continuing the investment in the public health infrastructure, data gathering, and ensuring that we're able to continue to see. Because if you can't see it, you can't then do anything about it. And I just wanted to thank the Public Health Department for that continued work and acknowledge that the board has made that local investment here so that we don't go blind to what's happening. And I'm very fearful that at a national level, we always rely on these national statistics and the national data and statewide data. And I'm very concerned that as the years tick by, we're going to collectively be blind. That won't happen right here in Santa Clara County for our data, but in terms of our ability to benchmark or cross-reference, that we are in a very, very disturbing place on that front.
I was hoping you could pull up that map, the Because I think just looking at it didn't really correlate from like my thought of, frankly, the economic, levels with health.
All right. Is that sharing for you, the map?
Not yet. Or, let's see. Hold on. There we go. And I don't know if it has to do also with like the population of these segments, but I just found it interesting that, contrary to what some folks, there's a part of like North County that has a lower life expectancy, than other areas, and just thought that was interesting to see that it's not necessarily correlating to the economic wealth of certain regions.
Right. I think that's very much some of what we see. There is a tool that's very helpful called the Healthy Places Index that our Healthy Cities team and our science branch use to understand what does the environment in a particular neighborhood, in particular census tract, have to create health or not. And it's everything from access to education, grocery store, how many tobacco retailers are in the area, how close are you to your doctor's office, how close are you to a freeway, and understand with those surrounding factors how that might be impacting somebody's health. Now, there are sometimes data complexities. I think it's always difficult to interpret Stanford University and understand, with the in and out population. So there are sometimes tricky places to try to understand, are the data really telling us the right picture? But what this does tell us is there's more than just race and income, that even though those are incredibly powerful predictors, unfortunately, there are others that we need to be paying attention to. And that's often why we talk about place-based interventions in public health, where we really want to go into a particular neighborhood, understand what's going on there that is causing a need, and how can we intervene.
Great, thank you. One last question. We talk about tobacco and drinking. How are we tracking cannabis?
We do have a component of our prevention team that focuses on cannabis. Unfortunately, we don't have anywhere near the amount of data to help us understand who is harmed by cannabis in what way, and at what level. We have enough information to know that there are concerns for everything from mental health impacts to driving safety to, sort of lung disease, especially given the different ways that people can consume THC.
Yes, right.
Right now, the public health department's work is very heavily involved mostly at the policy level, doing things like closing legal loopholes that allow sellers to sell what are called intoxicating hemp products, products that wouldn't be regulated like cannabis until somebody manipulates them chemically enough that they can intoxicate someone, as well as working with our city partners to understand access to cannabis and thinking about educational campaigns. But I think there's still a lot more we would like to be doing in that realm as well.
Great. Thank you. Thank you so much. And did I make a motion yet to accept the report?
Yes, I'll second that as well, and I do have a few questions to follow up as well. So following up the comment of James, I certainly do believe that we need to segregate the data of a higher number of differentiation in order to really get to the understanding the gap. For example, looking at the report as stated right now, Asians looks really great in terms of age and whatnot. But as you mentioned, Dr. Redmond, when you look into the Filipino and the Vietnamese community, those numbers are definitely not similar to the other Asian groups. So there are Cambodian communities, the Hmong communities, and as far as I know, some of those communities also have numbers just as bad, not worse. So I would like to see in future report if that's something that we could do, since we are such a diverse county, and we do have such a large population. Actually, in every group, if we could break those out in the future when we collect this data, that certainly I think could be very helpful for us to hopefully identify better gaps in terms of offering these type of services So is that doable?
Yes, I'm very interested in doing so, and I anticipate some of that will be covered in the agenda item next month requested by Supervisor
Great,
Bacoca.
thank you. Looking at that slide number 9, the one you see the circle, the 1098, which is talking about overdose deaths, alcohol-related deaths, homicide deaths, all we had basically like 10 times, 9 times, 8 times of Asian residents. Do we have other comparisons between the other groups, let's say African American and street versus Latino? No, I would like to see maybe just actual numbers, maybe if we could actually get those numbers into a chart. This is interesting to see the summary of that, but I would like to see maybe the one level below.
Sure, and
Yeah.
some of those are published in other specific areas. So for example, actually, each of the questions you've just asked are mentioned in the Latino health assessment in much greater detail because the focus there was health of our Latino community members, but looking at where there are disparities here. In general, I think what is fascinating here is, we're maybe one of the few areas of the country that uses Asian residents as our benchmark, as, again, only when you aggregate, appearing to be the healthiest community. But it really varies for different metrics where white populations fall and where Latino populations fall. So for example, for drug overdoses, African ancestry drug overdose rates are about double the Latino and white rate, which are about double the Asian, well, more than double the Asian rate. Or for alcohol-related deaths, the Latino rate is about double the rate in African ancestry community members. And then for homicide deaths, the African ancestry rate is about 4.5 times the rate among white community members. So you'll have some of those details in those fuller published reports, but we'd be happy to bring forth more details in a future report.
Great, thank you. You mentioned earlier that access to food is absolutely key to a healthy county. So access to food is one issue. And as we know, with different cultural groups, we have different food choices that we eat. Do we ever even look into that as a potential issues? I mean, I've been told by my family, like, stay away from that fried stuff. I'm sure we've all heard that, right? But how about that in terms of potentially advices that, or is this just the same refrain that we need to talk about in the future?
Well, one of the really fascinating things I've learned from the nutrition experts in the public health department is sort of two sides of a concept. The negative side is sometimes framed as nutritional racism, where often some of the cultural norms we find have grown up in the context of certain races and ethnicities having access to less healthy food more often than they have access to healthy food.
Right.
That said, the flip side of that is making sure that every time we intervene or support a community in creating their own intervention to improve nutrition, making sure it's done with cultural competence. I think showing up and telling a community, you can no longer eat rice, you can no longer eat tortillas. That doesn't make sense. But there are always other solutions that can merge both the cultural values, beliefs, traditions, the emotional connections we have with food, along with what we know about best nutrition practices, and find a solution that works for really every individual and certainly every community that's going to help them reduce their rates of their diseases that they're disproportionately hit by.
Great, thank you. Now, I just want to say thanks so much for the report. This is certainly extremely enlightening, and because once we have data, we could try to find out what these disparities are. The one thing that wasn't specifically stated here, but that was really striking to me previously when we did the African American infant death rates number a couple years ago by our colleague, I think it was Supervisor Ellenberg and Supervisor Chavez, that came out to identify that it actually wasn't wealth at all. Just if you compare it to the African American infant death compared to all the other races, that number is completely off the chart. When and the thing is, even those who are educated and wealthy, you thought they were the ones that would tend to do better. Based on that report, it was not. And so I think this type of disparity is is very scary, frankly, why this is still happening this day and age when we thought it was really more based on money or people's access to wealth and the care that way. So I just want to reemphasize that point, that is something that we still need to work on. And especially when we look at the percentage of our residents of African ancestry is really, really small. I think for our county, that number is down to below 3% and decreasing. So if that's the case, we could really identify, and if that's, I think we need to definitely make sure that we are highlighting these differences and try to focus on putting resources to work on this very distinct issue. I think is absolutely crucial as our most vulnerable population on these issues. And I would just say that this is certainly a very good start, and I certainly like to add with the motion we have to continue this conversation at the future HHC meeting, where we could certainly take a deeper dive in a lot of these data, such as geographic areas, incorporating feedback from the most impacted communities and our strategies moving forward, and think really hard of how to address these disparities based on these budgetary constraints that we have to face as well. All right, that's okay. Motion seconded. No further comments. Let's take a vote.
Vice Chairperson Abakoga.
Aye.
Chairperson Lee.
Aye as well.
Thank you.
Thank you very much. All right, moving to item number 9, which is the received report relating to the evaluation of Asian and Pacific Islander Community Health Worker Program.
Thank you. Well, since you've just heard so much of my voice, I'm pleased to introduce my colleagues who will take over from here. So I will pass off to Angelica Diaz. She is the director of our Healthy Communities branch. And in addition to many of the examples of public health in action I just highlighted, her team has overseen this important work in supporting an Asian and Pacific Islander community health worker program. So I'll hand to her to introduce our other colleagues. We offer the ledge file and are here to answer your questions.
Thank you.
Thank you, Dr. Redman, Chairperson Lee, and Vice Chair Abakoga. Really happy to be here to present on the report. I'm joined today by our program manager, Annie Wu, who led the project for the AAPI Community Health Worker. And then I'm also joined by Gerard Manuel, who is with AAPI and serves as the Director of Wellness Services, who led the project with AAPI. As you know, this is a project that was created out of the 2017 Asian and Pacific Islander Health Assessment, and it was meant to address the health disparities that were identified in that report, and it aimed to reduce barriers to access to care as well as increase opportunities to better access health information using a community health worker model. And so the report in front of you is an evaluation that looked to evaluate the effectiveness of this program. And we, at this point, we're happy to take any questions that you may have. Thank you.
Thank you so much. So let's see, anybody in the public like to talk about this issue today?
I have no request to speak on item 9.
All right, let's close that section. Yes, Vice Chair.
Thank you, Chair, and thank you so much for agendizing this item and for you being here today. I also want to thank AAPI and our other community-based partners, as well as our public health department, for really building a very strong and culturally responsive program that meets the people where they are. I see the growth from serving 3 communities the first year now to all of the 7 identified subgroups, and that's really great to see that progress. And I've seen with my work, I think the big, the real benefit or the game changer is being able to provide multilingual services and then having it rooted in the community. And I also appreciate the assessment, the honest assessment of the funding challenges we have. And that's really one of my questions is moving forward. Number one, I learned that the funding has ended from the county, I believe, and I think AAPI has been able to help acquire outside funding, but I believe that also ends at the end of this year. And that's really my question, is that, especially because the AAPI community continues to grow in population, like this is not a one and done, right? And we need to continue these efforts. And so just hoping you can share some thoughts on how we might be, and I might ask the county executive too, but how we might be able to continue. And this goes back to, you've heard me in regards to the budget process too, like rather than looking at starting new programs, like I just want to ensure that some programs that we should preserve are preserved first, and this would be one of them, frankly. So just some thoughts on how we can continue this program would be appreciated. Thank you.
Thank you. Public Health Department is committed to continue to support in several ways. One of those is with fund development, so we continue to partner and seek for funding opportunities. Another way is to leverage our existing programs in the Public Health Department. If you noted in the report, there were several activities that were conducted in the community around chronic disease prevention, and so we are continuing to leverage our programming at Public Health Department to ensure that some of the health information sharing continues and that we can point AAPI and the partner organizations to resources. And then the third piece I would say is to continue to promote the retention and recruitment of the community health workers in the network.
So how can we do that? I think we need funding to be able to continue to recruit and retain the health workers. So how can we do that if we're limited in funding?
Sure, if I may, I'll turn it over to Gerard, who can specifically talk about how AAPI will maintain some of those services.
Okay.
Thank you so much for having me here. Can you hear me okay?
Yes, thank you.
All right. For AAPI, we have been leveraging our grant development team, and we have been looking quite heavily into different opportunities. We have submitted a grant to the Sobrado Foundation, and we are waiting to hear back for the next 2 years. We have submitted another round. And we're also are finishing up one of our grants with the California Healthcare Foundation. And we did hear that they're also potentially putting out another round. So we are leveraging the talents of our development team and hopefully looking for other opportunities, because the primary cost of this is going to be the people who are doing the program in the community. And in the meantime, one of the biggest highlights we did want to share with you is that 3 of our partners have completed the process to become Medi-Cal eligible billing. One of our partners, the Korean American Community Services, just completed a readiness assessment, and they'll be set up for the fall of this year.
Okay.
And 2 of our other partners are working to complete their onboarding process with Pear Suites, which is a hub provider in the county, and hopefully they'll also be on board to provide that services. We are looking at a very strongly braided funding strategy that includes funding from revenue sources, grant funding, and donors.
Great. Well, that's really encouraging to hear, because I learned that it is hard to get Medi-Cal reimbursement. So that's great to hear that 3 of the partners have been able to qualify for that. And I very much appreciate the work being done and being assertive and looking for grant opportunities. Please keep us updated. And my question is, what is our plan B if those grants don't come through? So that would be maybe something internal that we can discuss at that time. But what I really noticed, one of the impressive data points on this was the number of encounters and virtual encounters at 1.6 million encounters, which is really quite incredible in light of I was thinking, 2 million or the API is 40%, so we're looking at about 800,000 people. So you've met maybe, obviously there's multiples, but almost everybody twice. And so my question is, how do we move from virtual to then, actually interacting with them more specifically to be able to respond or to provide whatever assistance they need? Have you thoughts on that?
The encounters that you're reading there is over a few years, and we have transitioned, many of our programs have transitioned into an in-person activity.
Okay.
And so a lot of the partners really have engaged their community, and what they have done is they've leveraged all of their assets from social media to newsletters to different mediums to really reach their community, including newspapers, or very ethnic-specific newspapers that has a wide reach. So the communities have started to work really towards an in-person model, and we are trying to support that.
So was there data captured or like contact information, for instance, from the social media that you're now able to actually outreach, in-person outreach to these?
Yeah, in terms of social media outreach, we have been able to capture the likes and the comments on site,
Okay.
and then the partners do track that very heavily.
Okay, so we have some sense of who these individuals are that we can follow up with them.
Yeah,
No.
and
That's
in
great.
addition to the social media, it does also include the newsletter and the membership access.
Great. Yes, so I don't know, Sheriff, could we make this a recurring update, get a recurring update at HHC on the progress of this program, or?
No, I think that's a good idea, but let me check with the public health officer. What do you think in terms of what's a
We'd be
good
happy to
frequency?
bring an update at your request.
Should we do it at least twice a year? Would that work?
Sure, thank you.
Okay.
And then please let us know in terms of the funding, how that progresses. Thank you very much.
Thank you. Do you have a motion to approve to receive the report?
Yes, and a motion to receive the report.
And I'll go ahead and second that. Supervisor Abikoga, I've already addressed a few of my questions here, so I only have one to ask. When we checked in with AAPI earlier, there was some discussion that the Santa Clara Family Health Plan was trying to enroll more new Medi-Cal clients prior to the end of this year to try to grandfather folks into the system. Can you explain why this is the case and what we could do to help support this in the next, 3.5 months? Is a very short runway, but how we can make that happen?
I'm sorry, you're asking about the enrollment for Medi-Cal before the end of the year?
Correct, yes.
Yeah, I believe the goal there is to try and reach as many of the folks and get them into the system before many of the changes kick in under the new legislation. And one of the great things that we can do to support this particular effort, many of our partners already in the community or in the network, they have been trained quite a bit on healthcare access information. And in many cases, they are very familiar with all of the different processes for enrollment and also all the different resources to get connected. And in this case, I do feel that the community health workers is a strong, trusted messenger network that can go out into the community and help with this effort.
Good. Thank you very much for this good work, and keep up the good work. We only have 100 days left, basically, and let's just punch and try to do as much as we can. Okay? I do believe one thing in life is deadlines. Sometimes when there's a deadline, things actually happen. So hopefully let's use this deadline to encourage more people to make this happen. All right, that's all I have, and we've got a motion and the second. Let's take a vote.
Vice Chairperson Abikoga.
Aye.
Chairperson Lee.
Aye as well.
Thank you.
Thank you very much again. Item number 10 is a received report from the Facilities and Fleet Department regarding the Child and Adolescent Psychiatric Facility Behavioral Health Services Center.
Thank you, Supervisor Lee.
Thank you,
Chair
Paul.
Lee, I'm happy to take this one. So construction on the new Behavioral Health Service Center is on track. We're very pleased to report that. We're looking at staff and stock scheduled later this year, around October, November timeframe, with an anticipated opening date of April of 2026. And obviously prior to that, we're looking at March for a ribbon cutting. So we are getting very close, and we are in the process of programming, obviously making sure that we're ready to go. So with that being said, I'm happy to take any questions.
Okay, no public, right? Jess?
I have, apologies, wrong screen, no requests for item 10.
Okay. Do you have a motion from my vice chair?
Yes, I will make a motion to receive the report.
I will second that, and just trying to go back to what Supervisor submitting would say is about those delay, and of course, he was very clear about any type of delay being put in. So in this case here, I know we were intentional. I mean, we initially were thinking about sometime in mid-25, then we pushed to the end of 25 and then early 26. Now we pushed to April 26, and I saw the reasoning behind that because of some of the stuff they dig in underground and whatnot. I guess my question really is, can we be more firm in terms of these dates instead of just pushing it backwards, Paul? Anything else that we could see?
Thank you, Supervisor. And I know Jeff Draper's here from facilities. I am not aware of any major obstacles at this given point in time to get us to the dates that we have presented in this report. In other words, moving to October timeframe for the staff and stock. And at that point in time, we'll start to move towards getting the facility ready for licensing with an anticipated opening date of, the end of the first quarter, April of 2026. So that is our target. Of course, one of the things that we're always leery of is when we deal with the state around licensing. Mm-hmm. So I just want to put that out there that, obviously we have to get the regulatory bodies to approve all of the programming of the new services because, as you well know, we do provide adult emergency psych services and acute inpatient services. Mm-hmm. Today, we do not provide children and adolescents, so we have to make sure that we have everything in order, and that approval, of course, from CDPH. And so there's a lot of work to be done. But from a construction standpoint, I think we're on task.
On the licensure issue, you said the application will be submitted in the future. It's not been submitted yet, right?
Yes, for CDPH, we have to submit the application along with a lot of other information, and we cannot submit it until which time we get approval for the facility in terms of our occupancy. But we will, of course, prior to that, be in communication with the state about our timeline. So they are very much aware of what we're looking to accomplish. And this process, just so you know, is not new to us. I can talk about what we're doing for labor and delivery at Regional Medical Center, but from my perspective, at this given point in time, what I can share with you is that we're on task. We're clear in terms of what our objectives are in order to meet the April 1st timeline. Mm-hmm.
Well, I guess my concern is if there's anything we could possibly do to get that package application earlier than later for CDPH, knowing how those delays usually are, I would hate to see that the construction actually is done, and then, oh wait, we are still waiting for licensure. That would be my biggest fear, I think, would be what I'm just going to share with you, and I'm sure just like the community as well.
Supervisor, I hear you, and we will make sure that we follow up accordingly.
Okay, great. All right, no further comments. Let's take the vote. Thank you.
And if I could ask you to move closer to your microphone.
Oh, sure,
going
of course,
forward.
yes.
Thank you very much.
Yes.
Vice Chairperson Abekoga.
Aye.
Chairperson Lee.
Aye as well.
Thank you very much.
Thank you. Moving item 11, which is the Santa Clara Valley Healthcare and Facilities Fleet Department relating to the De Anza West Valley Clinic. And I do see Jeff Draper, our FAF director, there as well. Good afternoon.
Supervisor Lee,
Yes.
Supervisor
Hi, Paul.
Abekoga, I'll take this item, and of course, as you noted, Jeff Draper is here to add in any additional information. So as you are aware, the Board of Trustees with the Community College District did approve a non-binding LOI back in June. At this point in time, as you also know, we are working with the County Executive Office around the 10-year capital improvement program to identify the funding. And that, of course, will be brought back to the full board for consideration. In the meantime, Supervisor Abekoga, you requested that we return to this committee and provide an update identifying short-term, near-term strategies to further extend healthcare services during this interim period of time. In the report, we did provide a couple of options, one of which, as noted, is the use of our mobile clinics. In all instances, in terms of our proposals that are presented in the report, we will have to further explore these options with the De Anza College District to determine the feasibility behind them. But I do think, as outlined in the report, we have some options for your consideration. With that being said, I'm happy to take any questions.
Thank you, Paul. No public to speak on this?
No request to speak at this time?
Yes, Vice Chair, go ahead.
Thank you, Chair, and thank you, Paul, for the update. Yes, as you know, this is a very important project to me. I know my predecessor worked on it, and as soon as I took office, I was getting inquiries and questions of when's the clinic going to open. So, lo and behold, when I learned that there was actually no funding allocated to it, that was why we began the conversation as to what we could do in the interim. But, I would note, and I know you've folks have heard me say this, but the West Valley region is really, when we talk about deserts, it is a bit of a healthcare desert. There's no healthcare clinic in that area. So it's for the communities, but also the De Anza College population. And, they pull from not just the surrounding areas, which includes like our areas, Cupertino, Sunnyvale, but because it's one of the highest transfer rate community colleges, it actually pulls from all over the county. So it's really a great location, I would say, to be able to provide healthcare services. So in regards to, and I very much appreciate the options that you provide in terms of interim strategies, and I would definitely be interested in looking at both, and I look at it maybe as phasing, or if we do the mobile clinic first, as we pursue what we could do with De Anza. And I did have a conversation with the president of De Anza College, and I believe they will be doing a space needs assessment sometime soon. But perhaps we can start that conversation with them and see if there is opportunity with the current footprint of including a expanded health clinic there. And then, I appreciate the CIP and the 10-year horizon we're looking at for actual build. But I do feel that there's urgency to be able to provide some kind of services as soon as we can. And so I would ask that we pursue the mobile clinic and then also engage in conversation about what the campus could provide space-wise. But I was thinking of going back to our federal update, earmarks. This would be, I think, maybe a earmark request we can make to the congressman who represents this area. I think he has all of this area, Congressman Liccardo. So could we add this to our earmark request list?
Yep, we certainly could do that. You're talking about in terms of capital related to the standing up the mobile unit?
Yes.
Yeah.
Or the, within the, if
Yeah.
there's some renovation opportunity.
We certainly could
I
do
guess
that.
the mobile unit is more immediate, so that would be the first request I would ask. And then I just wanted to also bring up the North County Clinic in Palo Alto. Thought I had was, I also noticed in Mountain View, there's the facility next to the Planned Parenthood site in Mountain View. And then I was driving on El Camino, and I think it's a dental clinic on El Camino, and it's very close. They're all within probably a mile of each other. And I just, my question is there benefit to looking for a consolidated space so patients I don't know what's happening in all of the clinics, but rather than having them, if there's like an individual that has to go to 3 different locations, is there a way of consolidating so it's a one-stop shop? And then if we do that, I believe these are all leased buildings, is there potential cost savings that could come from that we could apply elsewhere?
Thank you, Supervisor. We are actually exploring all of those options in terms of restructuring, consolidating service lines where obviously it will bring about savings, but continue to provide access. As an example, you've brought up the alcove program.
yes.
We're having very good discussions with the Behavioral Health Department to move that program into the Norris County Clinic.
Oh,
So we're exploring that.
Okay.
That's going to result in savings and actually probably provide more comprehensive services relative to primary care,
yes.
et cetera.
Yeah.
We are looking to move and realign services relative to the specialty clinic next to Planned Parenthood.
Okay,
So there's going to be changes there. And as far as the noted dental clinic, that is our standalone dental clinic that serves that entire area. And that clinic has actually been very successful, and it is the only quote-unquote dental site that we operate in that community.
Okay.
So we are looking at all of that. Much
good.
to what
Thank
your previous comments and ask about how can we become a little more efficient in serving that community.
Great. Oh, I appreciate that. Thank you very much. And then I learned or have heard that the Palo Alto Clinic's actually doing quite well, and there's a more diverse mix of patients.
Yes.
And I actually see this West Valley community having similar demographics, really. So that, having a clinic here at De Anza potentially could help in terms of cost recovery, I believe. So, yes, so I look forward to continuing to hear progress on this. Thank you very much.
Thank you, and get a motion to,
Yes, I would make a motion to accept the report. And could I also request, I don't know what the cadence of this update is, but could we have regular report outs?
I believe this is, as far as on schedule for regular report outs, I can get back to you in terms of that,
Okay,
but it is on a schedule.
okay, great, thank you.
moved and seconded. Let's go take a vote.
Vice Chairperson Abe-Koga.
Aye.
Chairperson Lee.
Aye as well.
Thank you.
Moving to item 12, which is the report from SCVH relating to acquisition integration of the Regional Medical Center, RMC. Go ahead, Paul.
Thank you, Chair Lee. So a couple items I want to take a moment to bring to your attention since our last meeting back in June. One, regarding review of regulatory compliance and verification. The California Department of Public Health did do their change of ownership survey, and obviously that was quite successful, no findings. We did have an unannounced accreditation extension survey from the Joint Commission, and that is our accrediting body for our health system. That was also very successful, no findings. And then third, more recently, we did have the Joint Commission come and do a verification survey for our thrombectomy-capable stroke center at Regional Medical Center. That too was successful, and we are now verified and designated as a thrombectomy-capable stroke center at Regional Medical Center. So quite a bit of work there, and really a shout out to the staff at Regional Medical Center. RMC continues to do very well with patient volumes continue to increase. The July average daily census was 167, representing a 21% increase over the month of April. So we continue to see a pretty steady increase as the months go by. Daily ED volumes remain high. RMC is averaging about 220 patients a day in their emergency room. Trauma activations reached a high of 193 in the months of July. And then, of course, surgical case volumes as part of our strategy is also increasing. We've seen a 65% increase in our surgical case volumes since April. And that's just the beginning, because as we start to bring in elective cases and so forth, we're going to continue to see an improvement in that area as well. With that being said, I'm pleased to report that the first quarter of operations, which April, May, and June, the last quarter of last fiscal year, the financials did show a $12 million favorable performance to budget. I point that out because our current financial structure as we are funded today, absent HR 1, we would probably be doing much better in terms of our outlook. And I just have to say that to the community, because not only are we providing more access in meeting the healthcare needs of the community, absent HR 1, the system would be doing really well relative to our financial situation. But that's not the reality of it, and I'll get into some comments later about what we're looking at. And the good news, and as you two are very much aware of, we've announced to the board and the community that we are looking to reopen labor and delivery through a restructuring plan within the healthcare system. The tentative date for opening of both labor and delivery and neonatal intensive care services, NICU, is tentatively set for October 20th of this year. The licensing application, Supervisor Lee, has already been submitted. It was submitted on July 16th. So we are moving forward and fully anticipate that we can do a ribbon cutting and community event on Thursday, October 16th, the week prior to the actual seeing of patients. With that, I'm happy to take any questions about regional.
I just wanted to emphasize a point that Paul just made, which is regional financially is doing much better than forecasted. When we did our pro formas and fiscal analyses associated with the purchase of Regional Medical Center, and the health system as a whole has significantly improved its financial performance in the last couple of years. And that is just a really salient point right now, because what we're facing in the health system is really the rug being pulled out from under us by HR 1 in an environment where otherwise operationally, both in terms of level of excellence, but directly in terms of financial performance, the system has been trending in a very positive direction. And the regional acquisition in particular, doing much better than we had even forecasted. And that's just something that the public should know and understand as we're staring down what's coming now with HR 1.
Thank you very much, James. Vice Chair, you have any motion?
Yes, no, good news in the midst of some really devastating news, but it's good to hear that how our regional's doing, and so I'm happy to make a motion to accept the report.
Well, thank you. I'll go ahead and second that. I just want to make it very clear. In a way, it really is a good news story that, when you acquire a hospital, we have anticipation of what the numbers would be. And in this case, the numbers we're getting here is beyond good. Mm-hmm. So this bad news that we keep talking about, HR 1, that's not us. We have nothing to do with HR 1. We opposed it. This is being shoved on us. So as far as what we can control, our county is actually doing very, very good. So I just want to say kudos to our team, James, Paul, and everybody who has worked on this acquisition. We are certainly very glad to see that, not only is it doing better, we are actually able to open up places like, the labor delivery, for example. That's somewhere that I actually hold a sign 5 years ago protesting its closure when they first closed it. I know that wasn't part of, even though our Valley Health System didn't own them yet at the time, but certainly labor and delivery is something that's very necessary for that whole region that serves Eastside and Milpitas and whatnot. So very glad to see that these things are actually working well, and I don't think that's something that the public actually understands as well. That I think we need to, not so much tooting our own horn, but let people know that this crisis we're facing is not us. This is being shoved by external forces. And so while in order to maintain or continue doing the good work we do, we need their help. Thank you. James, anything to add?
I couldn't agree more. And, you know, the regional acquisition has gone so smoothly. I think it has, you know, nothing's perfect, obviously, but the regional acquisition's really gone very, very smoothly in terms of the onboarding, the services, the survey that just happened, the financial performance. It has been an incredible transition, and I just want to, again, thank the staff there, but across the county organization who have made that happen and who are continuing to make things happen, including our upcoming labor and delivery services that will be there. These are huge efforts that involve a lot of folks, and they've done incredible things and done so on timelines that you don't see in the private sector. And that's another point that I think people don't recognize. You know, the HealthLink implementation, for example, is normally one that takes 12 months. And we did that in 80 days. And that's just an example of some of the really incredible things that are happening.
No, thank you. Anything else to add, Paul?
No, thank you.
Thank you. I know we're running a little late, so we'll go ahead and probably end the discussion now. Let's go take the vote.
Vice Chairperson Abikoga.
Aye.
Chairperson Lee.
Aye as well.
Thank you.
Okay, moving to item 13, our last item for today, which is the receiving report from our VH health system relating to current emerging healthcare issues. And first, do we have anything, Paul?
So I will be brief and then, of course, take questions. But as you well know, and James was able to join me along with Supervisor Lee on the Rehabilitation Center acknowledgement, being ranked 7th in the nation, top 10 in the nation, the top on the West Coast Rehabilitation Center, which is remarkable, but not surprising given the talent that we have within our healthcare system. Recently, we did go through a burn center re-verification. That was in June, and it was quite successful. So now we are once again re-verified with the American Burn Association for both adult and pediatric burn care at Valley Medical Center. So very proud of that. You know, the burn center complemented by a level 1 trauma center for both adults and pediatrics, that combination is critically important for this community. And once again, as we've said, you know, time and time again, until you actually are a beneficiary of those services, you don't realize how critical those services are to our community. So I'm very proud of the hard work of the staff. In about a week's time, we will have the opportunity to also have a celebration around the opening of the Compass Clinic, which is the addiction medicine clinic that the full board is aware of, and it's been under a lot of planning and preparation for the past year and a half, if not 2 years. So we will have a ribbon cutting next Thursday, August 28th at 11 a.m. to acknowledge that important service for the community. That program, just so everyone understands, was supported by Behavioral Health Department, the Public Health Department. We've received grant funding to support this program. So financially, this program has started off on a good foot relative to operations, but also financially and meeting the needs of the community. I can go through a bunch of numbers, but let me just say this to you. The month of July for the health system has been quite remarkable in terms of the volumes of patients that we're serving at all 4 hospitals. Just to give you a sense, the average daily census of all 4 hospitals is around 800 a day. Patients' admissions just in the month of July were close to 4,200. Trauma activations for just the month of July was 611 between Valley Medical Center and Regional Medical Center. Just think about 611 trauma activations. And then just in the month of July, close to 58,000 patients were served in our primary care and specialty clinics, just in 1 month alone. 58,000. So I just wanted to kind of share those numbers in terms of what your system is doing for the community. With that being said, I'm happy to take any questions.
Thank you. Anything, Vice Chair? Good. Thank you so much, Paul, for the update. I just want to mention, yes, echoing your point, Compass, why is this such a big deal? Is that this provides same-day access to a detox program, the time when the patient is ready and willing to be treated. And that's what the big difference is, because if you have the folks wait days later, a lot of them would change their mind and say, no, I don't need any more, I don't want to do it anymore. And I think that's why it's such a big deal. And I think certainly this is something that when people are so worried about in-house situation, folks who might be out there, well, these are the type of programs that will help many of those who need these services, including those in-house communities, and potentially lower those numbers that we see, on the streets and whatnot that people are so concerned about. So I think that's one of those programs I want to say, these are the good news why these programs are so important. And the funding cuts to us would affect these types of effects to the whole county and to community. Number one. Second thing is, on 611 trauma actuations you're talking about, basically the only two places we have trauma is the VMC level 1 and regional medical level 2, right?
So in the county, there are three trauma centers. The other level 1 trauma center is Stanford.
All right. So this included...
But in this area,
Stanford.
you're right. It's Regional Medical Center and Valley Medical Center, which serve the major portion of our county.
Exactly, right. Thank you. All right. That being said, that's all the questions we have. Thank you very much, Paul, for that. And then next we have our Public Health Officer, Dr. Redmond.
Thank you. I think just one item I do want to make sure folks are aware of, and a bit of a throwback. We are experiencing higher levels of COVID in our wastewater right now all across the county and all across the country, frankly.
Yes.
Fortunately, while these levels look actually in some ways worse than we saw this past winter and not quite as high as we saw this time last summer, we are not seeing the same levels of death and hospitalization we have with prior waves this high. Again, really testament to the high levels of vaccination here in our county. So I think for folks who are particularly vulnerable to COVID, especially those older adults, anyone who's unvaccinated, and anyone who has certain medical conditions that weaken their immune system, it is a good time to consider extra precautions when in crowds, such as wearing a mask. And there is still a great deal of unknown with what is going to happen with COVID vaccines this fall. One thing that has been evolving this week has been that while it's been deeply disturbing to watch the ACIP, the organization at CDC that is charged with making evidence-based vaccine recommendations, be essentially gutted and replaced with folks who are not relying on the best evidence we have to make these recommendations. We are seeing a university group pull in our nation's experts and begin public hearings this week, really in the manner that we expect to see from our federal government, in order to make sure that the best, most up-to-date science is evaluated and recommendations come from our medical experts. So I do have somewhere to look to, in the coming weeks, let the county know what the best evidence says is our recommendation for COVID vaccine. It's just unfortunately not going to come from our federal government for the first time in history. Will instead come from academic partners who are stepping up to do the work.
Thank you, Dr. Redmond. My question I have is regarding the COVID vaccine. So I had my healthcare check, and one of the things that, hey, you're not updated on your COVID vaccine. I said, oh, I didn't know I could get those still. And apparently it was still available. It was still free. And so I was able to get that day. So maybe a little PSA you could explain to the folks that this is still made available, and what would be the eligibility in terms of they haven't had it for how many days and they could be eligible to get it.
Right. So right now, the formulation that was designed for last year, but that is still highly effective based on the versions that are circulating in our community right now, is still available and widely for everyone aged 6 months and older. There is an approved formulation. And right now, every insurance is expected to cover it in full. So everyone who is insured should have a mechanism for affordable, if not completely free, vaccination. We don't know if and how that's going to change and when, because the moment should a recommendation come down from the new ACIP or the new CDC director or be superseded by the HHS director that alters those recommendations, it triggers a series of changes to things like coverage requirements by insurances that we are taking remediative steps to try to offset so that everyone continue to have access to a COVID vaccine. But I don't know if I can promise that the way I could last year. So right now, everyone who is eligible for a vaccine should have affordable access to it, especially everyone who is insured or has a doctor. Should that change in the future, you'll be hearing from me at this body about what it means for everyone and what the county is doing to offset it.
So basically, message is go get your free vaccine now.
Right.
Before it's not free anymore.
If you're due for a vaccine, and that's especially anyone who didn't get last winter's vaccine, or if you are 65 and older or have a medical condition that affects your immune system, there may be a recommendation for a second shot of last year's vaccine, and you'll be due for that even if you got one last fall or winter.
Great. Thank you very much, Dr. Redmond. No further comment. Okay, one more thing was measles. We had that one case that we tracked very carefully. And so far, after that, we have not had any issues here so far?
We have not had any cases. We
Cases,
continue, I think that, one of the frustrations with measles is it takes heroic efforts to keep us at 0 cases. Every false alarm, every exposure leads us to massive amounts of work. But with that hard work, every time we hear about a Santa Clara resident who flew on a flight with somebody with measles, we track them down, make sure they have the resources, and should they get sick, make sure we're making sure it doesn't spread. That has not happened due to those efforts and due to the very high measles vaccination rates we have in Santa Clara County right now. And there have currently been no changes to people's access to the MMR vaccine or the MMRV vaccine that protect people against measles. So if anyone doesn't know if they're protected, they can talk to their doctor and either get a blood test, get vaccine records, or go ahead and get vaccinated against measles to make sure that they're protected. And that's what's going to be the most powerful way we keep that near 0 number we have here in Santa Clara County.
Great. So the MMR, the measles, mumps, and rubella is
Yes.
still very much available.
Very much.
And I'm sure I got more than 2 or 3 times because the way the Navy works is they don't find your shot record, you're getting your arm punched.
Med school's the same way.
Yep. They don't mess around. So, all right. I think that's all we have on that one. Thank you very much, Dr. Redmond. And moving on, our Deputy Director, Behavioral Health Service Department, Darren Tan.
Thank you, Chairperson. No additional items to report, but happy to answer any questions you and Supervisor Margaret Abikova have. I do want to spend this special note of appreciation to you, Supervisor Lee, for co-hosting our opening of the August 2nd BHSA Community Town Hall session, as noted in the report.
Great, thank you. Vice Chair,
Thank you.
Go ahead.
Yes, thank you. I wanted to bring up, and there was some public comment earlier about PERT, and I know that we'll be having a discussion about the Trust MCRT and PERT programs at our September board meeting. But from the staff report and also some correspondence that I've seen from our staff, it looks that the impression that we're giving is that we've made the decision to end the PERT program, and I don't recall that we actually took a vote on that at the board meeting. I believe the direction was to bring it back in September to discuss potential transition, but it seems like the message that's being put out there is that we're ending it, and I just want to be clear, I personally do not support ending it. I've heard from many community members, our various public safety departments, especially during National Night Out. We were all out there, and I, talked to a lot of our law enforcement folks. And, I know one of the reasons for ending PERT, if I recall correctly, was the challenge of recruiting folks and then potentially moving the PERT staff over to MCRT, but I'm hearing that there may not be. It's very different. It is a different type of job, and so there may not be interest, frankly, in moving forward. And I continue to hear, my city of Palo Alto, even some of the West Valley cities and other cities are interested in continuing to help fund the program. And so I guess that's my question or my position. I think I just need to be clear that I do not support eliminating PERT completely. I think we should look at preserving some aspects of PERT, and I don't think that we made that decision as a board, and so I just want to make that clear that we have yet to discuss and make that decision.
Yes, go ahead, James.
So, the Supervisor, you are correct that there's an item coming back to the board regarding PERT. The budget that was adopted by the Board of Supervisors does end funding for the PERT program effective, I believe it's January 1 of 2026. So while there's an item coming back, including regarding transition-related activities, as well as options, for example, the one you just noted about cities providing funding to continue the program, from the county administration perspective, the county's funding for the program and those positions does terminate on January 1, absent a different decision by the Board of Supervisors.
So what are we saying to the cities that are, asking to continue and offering to fund their positions?
So I'm not sure what the communications department's having with cities who are offering to continue funding for the positions, but I do know that the communications regarding the county's funding of the positions is operating off of the timeline I just mentioned. And Darren, I don't know if you're in a position to talk in any more detail right now, or that's certainly something that we can make sure is explicitly included in that report that comes to the full board in September.
That is correct, James. One small update I do have to that, Supervisor, is we are finalizing some meetings with our law enforcement agencies to get back to the table with them and have discussion. So that will be topics that we are happy to discuss with our agencies.
Yes, I guess, I'm looking at it from a financial perspective. Just on the surface, I know we have to discuss it more in detail, but if we have funding sources, my question is, why are we looking to eliminate a program that has funding sources and maintain programs that don't have funding sources? So I think that's something that we should be discussing further. Thank you.
Well, we'll certainly include in that report any offers that we've received that are concrete from cities for the funding of the position. Sometimes there's a gap between what's maybe stated and what's an actual funding commitment for a position as well. So,
and I would say too that it would be worth, if we haven't, asking other agencies if they are interested in helping to maintain the program, because I from my conversations, I think there may be more interest than what we currently have. Thank you.
And do you have a motion? Oh, okay, I guess we don't need a motion on this, but reiterating that point, we hear the same thing about folks talking to us about sunsetting program being premature for PERT, and funding certainly is an issue, so I just certainly want to hear this report back. Is it coming back to us in September?
it's coming to the full board in September.
Okay, good, yeah, so I'm sure that will be a very lively discussion on this one. Yes, thank you. And of course, along with the challenges on the hiring on the MCRT team as well. I think I'm hearing issues there as well. So if you could bring that along, that would be helpful. Thank you. All right, next one, I believe, is our Valley Health Plan. Laura Rosas, please. Hi.
Thank you, Chair Lee and Co-Chair AAPI Koga. You have my report. Please let me know if you have any questions.
Nope, I don't think so. All right, I think that's all we have. So let's see, I guess.
Did we get public comment?
Oh, good point. Let's try, take a look at that. How about the public? Anybody would like to speak on item number 13?
I have no request to speak on item 13.
Okay, may I have a motion to receive the report on all on item 13, please?
Motion to receive all reports.
I'll go and second that, noting all the points being raised on this report as well. And without further ado, let's take the vote.
Vice Chairperson Abikoga?
Aye.
Chairperson Lee?
Aye as well. Thank you. And so this brings us to the end of the meeting, and we'll now adjourn. To thank you so much for all the work from my administration and clerk staff on next HXC meeting scheduled for Friday, September 26th at 10 a.m. at the Board of Supervisors Chambers, right here. Same place, same channel. No further ado. Thank you, everybody. Thank you.